is the Country Director, Global Financial Facility, and she is the Advisor, Health Emergencies for the Ministry of National Health Services, Regulation and Coordination. She is our discussant for today. We also have our speakers for this session, which includes Dr. Nabila Zaka, another mentor for me, and another person I really who inspires and from whom I've learned a lot in the past couple of years. Our other speaker is Dr. Samia Rizwan. I've worked with her closely, and she's very passionate about maternal and newborn health. And we also have one speaker who's the keynote speaker, Dr. Ashper Gam. I'm sorry if I pronounced your name wrong. He will be joining us online. Dr. Saima, with your permission, can we start with the presentations? Thank you very much. So I will request Dr. Nabila Zaka to please start with her presentation. And the presentation is titled Refocusing and Realigning Care for the Mother and Baby Dyad. You would like to come here or you present here?
There was a little understanding with Ashper that he would start.
Sure,
and
sure.
Sorry for that.
Dr. Ashper, over to you. And we are online and we are listening to you. Thank you.
Thank you very much, Madam MC, for the session, and pleasure and honor to be with all of you, honorable members of the Health Service Academy of Pakistan. It's really a pleasure for me to make this short introductory message that is very important meeting goals for me. I had the pleasure of visiting Pakistan, working with our UNICEF Pakistan team, Dr. Nabila, Dr. Samia, Dr. Hari, and the provincial teams as well in June of last year. And I had the pleasure to visit up to from National Ministry of Health and national workshops up to the level of communities and districts. And this picture is from the Lady Health Worker session. And it is one of the most memorable pictures of my entire public health career, because I could clearly see the power of community health and public health, one. So I cherish it very much. And I was also able to see that Pakistan is one of the leaders of global leaders in public health, which maybe is not so much celebrated also globally. So it was a really great opportunity for me to note that as well. I work at the regional office in South Asia. I support maternal and newborn health. The regional UNICEF regional office supports 8 countries. As you will see, we work very closely with the UNICEF country offices, which are also supported by the provincial offices. As you see, we have 4 provincial offices in Pakistan and about more than 50 across South Asia in the 8 countries. UNICEF has 7 decades of trusted partnership within South Asia. So it has been working with all the countries since their independence, including in Pakistan. So the South Asia has been transformed in the last 70 plus years where UNICEF has worked, and UNICEF has been is honored to have been part of that process. If I don't have enough time to finish my presentation, I just want to say these key messages. This is what I have come to say during these speeches. 1, maternal and newborn survival is a human right and collective global commitment. That is very clear to all of us, but I just want to start with that. Two, there is a solid policy framework in South Asia on MNH. We know what needs to be done. There is no country in South Asia that doesn't know what needs to be done. We know because South Asian countries have been doing it, and it is very solid. You cannot find loophole in South Asian MNH programs. South Asia has paved the path to success. We are already there. We are on the road. So we are in what's called the last miles of the journey to end premature perinatal mortality in the region. And the last miles, be it health program, marathon, or anything, are the most difficult, as you know. So we are in the difficult part, but we are definitely in the last miles. All 8 countries that we are working in. For maternal and newborn, SDGs are doable. That is the consensus within the region and in all countries. The trends and the achievements are clear. So we are not talking about very difficult or impossible things. These are doable by all the countries. That is the consensus. The 5th is very important. We have all countries have solid national maternal and newborn health program. There is no problem in the programs. There is solid programs. There are solid programs in all countries, even including Afghanistan. So what is the challenge? We lack a maternal and newborn national social agenda. To achieve an accelerated agenda such as the SDG in a very short time, a program is not sufficient. We need to transform that program into a national, social, and political agenda, and we need to work a bit on that. That is what is lacking in all of our South Asias, and that's what we need to do if we are to move to accelerate towards the SDGs. I understand that one of the mottos of this Health Congress is no business as usual, but I want to modify that. I am kindly requesting to modify that because we are doing a lot of things in maternal and newborn health that are very effective. So business as usual must continue, yes, in many things, but at scale. The only thing missing in many of our business as usual is at scale. But there are some things in which we know business as usual is very clear. So I would like to stress on those issues as well. The policy framework for maternal and newborn health, which all of you know, is very clear, and it is a global policy framework. In preparation for this session, I have tried to go through all of them, and I was very surprised that there are very, very clear articles in the entire policy frameworks on maternal and newborn health. 4 articles in the Universal Declaration of Human Rights directly on maternal and newborn health. 3 articles in the UN Convention on the Rights of the Child. About 4 articles in the CEDAW, Convention on the Elimination of All Forms of Discrimination Against Women. 4 articles very, very clear in the Sustainable Development Goal Agenda, and significant articles also in the Global Strategy for Women's and Children's Health. So there is a clear global commitment, and there is no need to repeat this because Pakistani academics and renowned persons from Pakistan, legal experts and so on, have actually participated during the crafting of each of these documents. So this is very much a Pakistan-owned document, all of them. It's not something that was, crafted somewhere and came. Actually, during the preparation, even the Universal Declaration of Human Rights in 1948, a lot of contribution from Pakistan on that. How to do it? Now the issue is how to do this. These are the 2 global frameworks that detail how it will happen. All of you know them. One is the Every Newborn Action Plan that was launched in 2014. And Pakistan was one of the 10 pioneer countries, as you know, in which the Every Newborn Action Plan was piloted before it was launched globally, and the Ending Preventable Maternal Mortality Framework. This detail what is the strategy, what are the activities that needs to be done, what needs to monitor, what are the targets, including specific targets, as you all know. We are currently in the process of the global team is in the process of combining or strategizing to combine the two frameworks, which are largely very similar. And Pakistan has been selected as one of the 7 pilot countries in which the joint action planning will be done and implemented. This is because of the strength of the implementation of these 2 initiatives in Pakistan. Another country in our region also is Bangladesh. So we are currently working, all the partners are working in close collaboration with ministry to implement that joint planning. This graph is very critical. I know all of you know it, but I'm just repeating it. There are many things to improve maternal and newborn health. So we need focus. We cannot be running all over the place to improve maternal and newborn health. Where do we need to focus to get the maximum impact? 2 interventions have been identified very, very clearly with a high impact. One is skilled birth attendance, and one is the care of small and sick newborn care. If we can focus on these 2 interventions, maximal reduction in the 5 million estimated child deaths and about 50,000 estimated maternal death in our region can be accelerated. This is a skilled birth attendance and care for small and newborn care units. Where are we? We are doing remarkably well as a region. Huge reductions in maternal mortality in the last 2 decades, which you all know. We are currently, MMR is 163, which is much, much better than the global as well as some regions in the world, but we are a bit far from the SDG targets. And some regions are ahead of us, as you know, and some have already achieved this target. So we need to accelerate, that is very clear. All our countries except probably Afghanistan are in what's called the low maternal mortality region. Pakistan is at 140 by the last DHS, as you know. We need to accelerate to the 70 targets, and that is fast. We are not on target in accelerating. If we go by the current rate of reduction, we will not achieve. That is very, very clear. Newborn death, we have done again a lot in the last 3 decades, as you all know, but we still have about 850,000 newborns dying in our region. We are contributing 1 out of every 3 newborn deaths every year from our region. And more importantly, 62% of child mortality is now in our region from newborn death, as compared to 50% globally. So we are having the maximal amount of newborn mortality in our region. When we look at the 8 countries that we are working on, all of them are rapidly reducing. Even Afghanistan, you can see rapid reduction over the last 3 decades. Pakistan, rapid reduction. But when you look at the rate of acceleration, we are a bit lagging behind compared to some of the other countries. And of course, this is where we want to be, when this is where our mothers and newborn deserve to be. Even from the global average, we are a bit higher. So the newborn mortality, we need to accelerate. These are the graphs again, because of the number of deliveries, these are the graphs that we are looking at. And this is the graph that the global team is looking at and is worried about South Asia, because nearly 1/3 of the global mortality is from our region. When we look at the countries, the 8 countries, again, India and Pakistan contribute the majority of newborn deaths, because the number of deliveries in these 2 countries is the highest. The stillbirth rates, again, our target is 12 stillbirths per 1,000 deliveries, but we are struggling, as you can see. And for Pakistan, we have a bit higher rate. All the countries need to accelerate, except a few countries that have already achieved this rate. All of us, and as a region, we are a bit far from the target. So we need to accelerate. Again, the numbers, our two countries, India and Pakistan, because the large number of deliveries in our countries, we need to contribute a significant amount of the 651,000 estimated stillbirths, 340,000 from India and about 190,000 from Pakistan and Bangladesh a bit, and then the other countries contribute less because they have lesser number of them. This is very worrying because 50% of stillbirths occur during labor. 50% of the deaths in stillbirths out of the 615,000 is during labor. One day, one event. That is where we need to act equally. So where are we with the SDGs? In all the three MNH SDGs, we are struggling as a region. We are doing a lot, we are reducing, we are on track, we are in the last miles. But unless we accelerate in the coming 7 years, we will not achieve as a region. Some countries may achieve, but some are really struggling. These are the projected years estimates, if we continue with the current annual rates of reduction. What shall we do? We are doing significantly well. Skilled birth attendance is now 88% in our region. In facility birth is 82%. But we need to make this, all of this need to reach 100% because these are the essential life-saving services. As skilled birth attendance is increasing from 40 in 2000 to 82%, look, all the triple mortalities are rapidly declining in the region. This is very clear that this is a key intervention. How are we doing with the countries? 4 countries are approaching universal health coverage for skilled birth attendance in the region. Maldives, Bhutan, India, and Sri Lanka. They have rapidly accelerated over the last decade plus, and they are there. The remaining 4 countries are rapidly accelerating. As you can see, the graph is very clear. They are very determined, they are working. But the gaps towards 2030 are large in terms of skilled birth attendance, which is a single most important intervention out of the 2 interventions as we have seen. So we need to rapidly increase this acceleration, these curves, to achieve universal health coverage in skilled birth attendance. These are the gaps because the contribution of deliveries from the countries are different. In terms of the deprivations, we have an estimated 6 million plus mother-baby pairs without skilled birth attendance every year out of the 35,000 deliveries in our region. This is huge, this is unacceptable. And with this degree of skilled birth attendance in the region, it's very difficult to achieve the mortality indicators. But when it comes to numbers, because of the number of deliveries, India has the highest contribution of maybe skilled birth attendance, and then second would be our country, Pakistan, and then the other countries also contribute. Huge inequities. This is not uniformly distributed gaps in skilled birth attendance. Geographic inequities between rural and urban. The poorest quintile is almost 35 points less than the richest quintile, and mothers with no education, again, have gaps. So we need to identify where are these communities, do the equity analysis, and so this is what we can say. We need to sustain what we are doing. We are doing a lot of good things. Our ministries, our policy leaders are really should be thanked for the great achievement of the last 30 years. But what we are missing one thing, that is a scale. Universal health care. We can mention some. The Lady Health Workers Program, excellent public health initiative in India, but we have not achieved universal health coverage. We need to do that fast. Maternal and newborn care strategy, solid program in Pakistan. We cannot find any loophole in it, but we are struggling with universal coverage. We have not reached every mother and every newborn. Provincial health programming, excellent and pioneer program in Pakistan. And a lesson, a model lesson to the region. But we need to reach all the other provinces where I think currently we are doing it in some of the provinces are not doing provincial programming. Health management information system, again, we need to strengthen that. Quality of care, huge strides being made, but we need to make all the initiatives universal. Low cost, high impact and managed interventions, many of them Pakistan is piloting actually in the region. Kangaroo mother care, we have the strongest models in Pakistan in our region. PBSI, essential newborn care, antenatal corticosteroids and so on. But they need to reach all mothers and newborns. So scale is the key. BMOC, CMOC, again scale. So business as usual, but at scale. These are the strategies, all of you know them, and kudos to also the Health Service Academy for the great leadership in policy and guideline and programs, and implementation as well and monitoring. But we need the scale now. No business as usual. I am kindly, proposing or requesting support from the Health Service Academy as a policy body in Pakistan to support or consider at least the below as the policy framework or acceleration agenda in the coming years. One is a flagship social agenda for maternal and newborn health. We have strong program. We don't have a social and policy agenda. So we need to craft a policy agenda or social agenda that can be understood by all key social audiences like media, like policymakers, political leaders, the common man on the street, academia, and everyone on maternal and newborn health. We don't have that now. So technical program that is only limited to technical partners and so on will not achieve rapid acceleration. It will go at its own pace, at its own, thing. This is what we are proposing. For example, home delivery free Pakistan, that is could be one. Universal skill birth attendance in Pakistan by 20-something. Some countries have crafted it like no mother should die while giving life. That is an agenda which I remember in one country. Or we can craft something, but we need a social agenda, and we are proposing, skilled birth attendance as one potential social agenda for kind consideration.
Dr. Ashper,
Yes.
sorry, I'll request you to please wind up in 1 minute. Thank you.
Sure. So the other proposals are ensure at least one small and sick newborn care per district. District health mapping and programming. We are currently at provincial level, but in all countries, health district planning and programming is another policy proposal. Mainstreaming the private sector. The private sector is 1/3 of all care, so we need to mainstream. That is one thing we are proposing. The private sector is at the periphery of health systems. Again, structure partnership with health professional associations, with healthcare providers. That is a key thing that we are working on. We don't have structured partnership with health professional associations. So we propose that as one policy framework. And then in health emergencies. And the last is family spacing and family planning, because that seems to be a key gap in our MNH priorities, and it is a key impediment. So we are I'm kindly requesting Health Service Academy to consider that. How do we rapidly accelerate on family spacing, particularly, but also family planning, so that couples and families have their own choice. So these are the proposals that we are proposing to Health Service Academy for kind consideration. Midwifery model of care is the last one. And these are the demographic projections. So whatever we are doing for our MNCHA we are doing for at least the coming 100 to 150 years. They are worthwhile investments. They are not just for the SDGs. I would like kind consideration on this graph also. So thank you very much for this time, but very happy to address any queries from colleagues. And thank you for consideration of these policy proposals in your further work. Thank you.
Thank you very much, Dr. Ashper, for your keynote talk. We will take the questions after the two speakers have also presented, and Dr. Ghazna would then lead the discussion. The speaker for us today, the first speaker for us today is Dr. Nabila Zaka. She's an advisor with UNICEF, and the title of her talk is Refocusing and Realigning Care for the Mother and Baby Dyad. So, Dr. Nabila.
Assalamu alaikum. I think we had a very good background setting by Ashibar. Thank you, Ashibar, for that. And as you can see, the focus of our today's thing is that how we can refocus, the precision when the resources are limited, the precision matters in our programming and in our policies, and how we can realign the care so that it becomes more cost effective. For the family, for the mother, and also the baby. Okay, so we have listened a lot about the targets. And in the 7 years, of course, we have the maternal mortality ratio to decrease to less than 70, to end newborn deaths, to end under 5 deaths. And there is a need, of course, for funding, policies, and action to collectively fill gaps and address roadblocks for advancing maternal and newborn health and ending preventable stillbirths in support of ENAP and EPMM coverage targets. I think you all received this document. So there is a global advocacy and accountability working group, which is bringing together the maternal health and newborn health leaders to work together and to see, how we can support countries together. And in that, there have been identified phase 1, phase 2, and phase 3 countries, and Pakistan is among one of the phase 1 countries. And why should we be focusing on the diet? Why we have been working on one or the other, but how we can work together. So first thing is why we should do it is because it's connected. And then stillbirths are lying in between. And then we also know that these are among the poorest families and most of these deaths are preventable. So focusing on the equity angle also benefits both. And also that addressing the health needs of women during pregnancy, labor and birth and postpartum period together with those of their newborns with integrated planning services and strategies makes intuitive sense. And what are the causes? We all know what kills mothers and what kills newborns, but these are also linked. When we are talking about anemia and PPH and hypertensive disorders, we also know that for sometimes to control the blood pressure, there might be a preterm baby delivered. And that baby has also a heightened risk of dying later. So things are very, very connected. Then we have also opportunities for synergies where we can interconnect, for example, around the critical periods of care for both women and newborns, primarily at the time of birth, where these overlap. And also the complications in labor may cause maternal, fetal, or newborn death and long-term disabilities. So focusing at that time is important. And collaboration along the continuum of care is necessary to realize our goals. So there is an article, and I was so proud to look at that there are many Pakistani writers, Pakistani origin writers in that, and they have looked at the interconnections between maternal and newborn health. So this is not very readable, but it talks about at the postnatal time, at intrapartum time, at antenatal time, at preconception time. And it also links with the nutrition angle as well and adolescent angle. And when we are talking about integrated continuum of care, it would benefit, of course, both. And also at the pre-pregnancy, pregnancy, and childbirth, there are many, many interventions which are also benefiting the newborn, mother as well, but newborn as well. And when we are talking about, and we talked about it, that the bleeding, hypertensive diseases and infections are the major causes for maternal mortality. But they are also linked to the neonatal death causes like infections, how was the care around the birth? Complications arising from preterm birth and also the intrapartum related neonatal deaths of birth asphyxia. And if we are talking about the continuum of care, we are looking at, two angles. One is the continuum from household to community to health facilities, and another is the continuum across the phase of the pregnancy and childhood. So here comes like the crux of my today's talk. This was a report released in 2020 by Ministry of Health and HSA. And we looked at what has worked, what has not worked, where are the gaps. And we interviewed a lot of people for that and did a data analysis. But then came, okay, what we are suggesting, does it make sense? How are we going to validate that? So we used list model to put all interventions that we were, I would say, recommending for UHC coverage, or for our SDG targets, to look at that when we are saying that we would raise SBA attendance to X% and prematurity coverage to X%, what does it mean? Does it lead us to achieve SDGs? So this is all projections. I acknowledge our colleagues who worked on it from UNICEF headquarters, and also this work was done with Health Services Academy and University of Manitoba. So these are the data sets that were used for this analysis. So in the scenario one, we looked at the coverage rates that need to be scaled up to 80%, and that's from the government's own SDG targets. So if you're talking about 80% by 2025 for ANC4, for SPA, for basic comprehensive EMOC, essential newborn care, small and sick newborn care, treatment of diarrhea with ORS and zinc, pneumonia with antibiotics, full immunization, hand washing with soap, and improved water supply. So what would be the results? And then we worked with that scenario and added family planning to increase contraceptive prevalence rate by 20%, as was projected in the government document. So here is the result. In the scenario one, you can see we were reducing newborn deaths, stillbirths, maternal deaths under 5 deaths. But as we added family planning, it had a multiplier effect. And you can see there was a like 18-point difference in the neonatal, same in the stillbirths, there is a 17% percent points difference, and also in the maternal mortality, kind of 18% points, and also in the under 5. Now look at the neonatal deaths averted. This is where we talk about refocusing, where our energy should go. So when the model works, it also talks about which are the deaths which it is targeting, which are the deaths which are being reduced. So you see, our highest impact comes for reducing asphyxia related deaths. That is all the HBB work that we do. And the prematurity related, that's the biggest one. So if we focus on small and sick newborn care, that would be the best investment that we can make. And the second best investment would be asphyxia. So if we don't have resources for everything, at least for the things that makes the biggest dent. So see, same for the maternal deaths. Our highest impact is on postpartum hemorrhage deaths. From tomorrow, why can't we start a program called Zero PPH deaths? We can. We have the solutions. We have extremely great obstetricians in the country who have modeled in their settings. And they have shown that this can happen actually. And then comes the sepsis. But there was also a very interesting analysis of the mortality survey data by HSA, and Dr. Farid did that, and he showed that between the two mortality surveys, maternal mortality surveys, sepsis deaths had decreased, but PPH deaths and eclampsia related deaths did not, were not as a percentage, did not decrease. So it means also, like, you know, what is improving and what is not improving, we should be really focusing. Same for under 5 deaths. Above that, where it's NN, it's all neonatal. Yeah, so we already talked about the sepsis and asphyxia, but and prematurity. But when we go to the post-neonatal, the biggest dent is for the diarrhea. We can put in ORS and zinc, because for ORS, almost 30% in the last PDHS used ORS when the child had diarrhea, but only 8% also used zinc. So where are we lacking? You know, the co-packaging, and also in our awareness and with our lady health workers, where the message can go. So of course, you know, we need to refocus precision. Where are the deaths coming from? What can give us the biggest dent? And then realigning with the little money we have, how we can make it more efficient and to work for us. Thank you so much.
Thank you very much, Dr. Nabila, for identifying the initiatives which have been taken and the work which has been done. Dr. Nabila is being modest when she says that Health Services Academy did the work on the life save tools and the scenarios. Actually, Dr. Nabila led the work. So it's more of her effort than anybody else. Our next speaker for today is Dr. Samia Rizwan. Dr. Samia Rizwan is with UNICEF. She's a health specialist in the maternal, newborn, and child health unit of UNICEF. She will be talking about country progress on ENAP and lessons learned.
Assalamu alaikum, dear colleagues. Thank you so much. I would like to thank Health Services Academy for providing this opportunity to me to present and to share the progress update, which is on every newborn action plan. So basically, this is a long journey we have taken up in Pakistan, and I'm here today to share with you the challenges and how we want to go ahead. What are the opportunities? What is the way forward for all of us, and how we should realign and refocus our strategy for future. This is not working. Okay, so basically, as you see the slide, you'll see that despite the substantial reduction in under 5 mortality, neonatal mortality still remains a challenge for Pakistan, as the contribution of neonatal deaths to overall infant and under 5 mortality had proportionately increased over years. This is a cause of concern that for the last decade we are trying hard, but the proportion of deaths has increased in terms of newborn deaths. So these deaths mostly occur in the first week, first day, and first hour of life, which is very important to understand that how we have to focus our energies and how we have to strategize and how we have to see where we have to focus. Now, we know the causes, and these are the very clear causes, and over 2/3 of these deaths are preventable. So these are prematurity, birth asphyxia, and sepsis are the three causes. Where are these newborns dying? We need to think so that we can plan for future. They are dying in the rural areas. They're not dying in the big cities or urban population settings. Things are changing. Maybe in future we'll see a different setup, and maybe there'll be more deaths in urban populations and urban settings. But right now, as PDHS data showed us in 2018, they're dying in the rural areas, in the laps of poor mothers, in the laps of uneducated mothers. So we need to understand that where we need to focus. Now, we know that there are huge missed opportunities. Antenatal care has improved, skilled birth attendance has improved, institutional deliveries have improved. So it's very positive thought, but why these newborns are dying? Because there are huge missed opportunities. Even breastfeeding improved, PNC improved, but neonatal mortality is still low because of quality of care. So lots of women are coming for antenatal care, but they are not given quality care. उनका ब्लड प्रेशर चेक नहीं होता, उनके वजन चेक नहीं होता, उनके साथ काउंसलिंग नहीं की जाती, उनको टीटी के ऊपर नहीं बताया जाता. So that's why these newborns are dying. Now, every newborn action plan process started in Pakistan in 2014. Basically, this was an international initiative. Countries got together and they discussed bottlenecks for why we can't save newborns and mothers. And Pakistan was one of the 10 countries in the world which contributed to development of this document. And we provided in-depth analysis. We went from province to province. We had national consultations, and we contributed to this very important document, which was launched at the occasion of World Health Assembly in 2014 and was endorsed. This document talks about three important messages, which I want to give in this slide. Basically, the first message is that the care around the time of birth saves mothers and their newborns and prevents stillbirth. So first message, care around time of birth. This is very, very important. A lot of problems can be solved. Second, high coverage of intervention. So like Dr. Asheber, Dr. Nabila said, that it won't matter if we introduce things. It will only matter if we scale them up. So that is the second very important message we got in this document. This is a package of interventions. So all these interventions are important. They need to be introduced and scaled up. And third and very important message, that delivering healthcare to women and newborn requires coordinated effort between technical programs and initiatives and collaboration among all stakeholders. This is very important. Like whether it's the Ministry of Population Welfare, whether it's a Ministry of Climate, Ministry of Environment, they all need to work together. It's not just health. So this is very clear, and we need to very clearly understand that if health keeps on, doing everything, we will not achieve our results. Now, it's very important, equally important, rather very important to track progress. If we do a lot and we don't track progress, we will not know where we are standing. Maybe after 10 years, we have not made any progress, but we won't know. So it's very important to track, and this document talks about a set of core indicators which need to be actually tracked. And unfortunately, they are not part of DHIS to date. We are struggling hard. UNICEF is struggling hard. We are working with departments of health. We are trying to get them inserted in that system so that they automatically we see the results. So this is a very important point I'm trying to make. Now, there are 5 strategic objectives of this plan. First, to strengthen and invest in care during labor, birth, and first day of life, as I said. Improve quality, like I said. Reach every woman and newborn. So inequities are very important to be addressed. So a child dying in Islamabad is equally important to a child dying in Gilgit-Baltistan or Skardu. So it's very important to address every newborn, but especially those who are hard to reach. Harness the power of families. I think it's very important to make them a stakeholder and empower them and count every newborn like the indicators I showed. These are some of the glimpses of different consultations we undertook in Pakistan, and we provided in-depth bottleneck analysis for this process. Now, after that, it was tracked every year. And this is one of the snapshots from a recent report, which shows you a comparison of different countries. And you see Pakistan, we have almost 4 red areas where we are, other countries have done so good, we have not achieved that. One of them is newborn action plan. Second is stillbirth reduction target. Third is care for the sick and small newborn. And fourth is incorporation of indicators in newborn in DHIS. Like I just mentioned, we are still struggling. Now, UNICEF started this year, we started working on National Newborn Survival Strategy. So we are trying to, overcome this first red mark. Second, we are trying to work on the standards for sick and small newborn. And very soon you'll see it's a joint collaboration with WHO. There will be clear standards for sick and small newborn. Here you see that the annual rate of reduction of newborn mortality is 2.2. But we need the annual rate of reduction 32.6. And only then we can reach our target. So do you think this space is, this progress can be made? So we have to really multiply our efforts. This is very, very important. Now, recently there was a new report released, which was ending preventable newborn deaths and stillbirths. And it talks about 4 best buys. So they say that, okay, we know that pace is not possible to be met. So if we take a lot of progress in these areas, then we can overcome our issues. First, antenatal care. Second, skilled birth attendance, postnatal care, and newborn care in hospitals. And this can help a lot of lives can be saved. And as Dr. Eshabar also pointed at this thing, Dr. Nabila also pointed at this thing, that it's very important to ensure that these 4 target areas are achieved with quality. Now, recently, very recent thing in October 2022, couple of weeks ago, now they have introduced a new tool, which is actually merging of ENAP and the maternal tool, which is EPMM, which is ending preventable maternal mortality. And they were separate tools. They have merged the tools. And now I'll be soon inviting you all to sit together on one forum to work on this tool. And our progress will be gauged on this tool from now onwards. It talks about 5 new targets. There were ENAP targets and EPMM different targets. And as Dr. Nabila said, most of them are linked. And there are 10 different milestones, which you can go to the link and dig into further details. So these are the new, this is the new initiative, and please go to Google and search for it, and this would be the new tool we'll be following. Now, here I would like to take a minute to share with you that a lot of good things have also happened in Pakistan. And we must celebrate that. There are lots of opportunities. There's a strong political will. There's a scaling up domestic investment for improving health and nutrition, fully devolved health structure, Asas poverty reduction strategy, which is very good, social health insurance scheme, which is Sehat Sahulat program, and 170 people have been enrolled. Yesterday, Dr. Arshad was with me in a session, and he shared that Pakistan is one of the only countries in the world with so many people enrolled in a social health insurance program. And we have a national vision. This is the picture of the national vision. We have HRH vision with us. We have a priority, government is focusing on UHC, and they have developed essential package for health. National strategies highlight the focus on quality of care. And 3 out of 4 provinces have healthcare commissions, as you know. And there's emphasis on strengthening collaboration with private sector. At every forum, this is being spoken about. New innovations, digital mobile apps have been introduced, and Punjab Ambulance Service Program is one of the examples. And there's strong presence of development partners. As you know that there are so many development partners available to help. Evidence-based effective interventions have been introduced, like KMC, sick newborn care, chlorhexidine, HBB, they have been introduced. And there are some standards which have been adapted for Pakistan. So a lot of good things have happened in the last 10 years. SOPs for management of COVID-19, they have been approved and disseminated. And new vaccines have also been introduced in Pakistan, such as MR. There are 4 provincial newborn survival strategies which were launched. And now we are working on the national newborn survival strategy. So these are all good news for us to see the progress we have made. Quality of care strategic and accountability framework, a close collaboration with HSA. It was the final draft was disseminated in December 2021. And now we are going to provinces to work on the implementation plan and work in selected UHC districts. And WASH in health facility strategy is also almost ready for dissemination. It's under designing and printing. It's a huge step forward because there were so many facilities with no water available, no sanitation available. So this strategy would be the right step in the right direction. And PSBI, another very important initiative, a quality initiative, has been scaled up in 10 districts of Punjab. Standards for sick and small newborn care, like I just mentioned, they are being made by a national team of experts, which also includes international experts like the Professor Bhutta and a lot of other professors from UK and other countries. And we are working day and night on this very important initiative. And home-based newborn care, which is a very important initiative, joint venture of UNICEF and Ministry of Health, has been scaled up across the country in various districts. KMC is also scaled up in 34 plus districts. We had a national stakeholders consultation on kangaroo mother care, and these stakeholders were highly appreciated and they're scaling up the work. And World Prematurity Day, every year we celebrate. This is the month and we'll be celebrating again, World Prematurity Day. And in sick newborn care units, we have supported 45 plus sick newborn care units across the country. So what are the gaps? So this is the slide which gives you the message that there are gaps in leadership, availability of resources, missing data quality, rural and poorest households left behind, and linkages with nutrition and WASH. And we need to fill in those gaps very soon and very strongly. Now, priority recommendations, leadership, coordination, policies, and financing need to be further looked at. RMNCH acceleration package with family planning. I think there's no newborn or mother's health without family planning. We all need to work on that. And quality of care, private sector, which will help increase demand. Then MPDSR, measure trends and disparities, DHIS, CRVS, referral networks, human resource, linkages with other sectors. So all these policy recommendations are extremely important. So I just want to conclude by saying that Pakistan has made significant progress in terms of newborn health when it was absent from the national policy. We should not be pessimistic. We should be optimistic to say that, yes, it was not there 10 years ago. I remember when I started working, newborn health was not even mentioned 10 years ago. So 2000, it was not there, but now it is receiving increased national focus. So something right must have been done. So successful advocacy and interventions were introduced. Evidence generation, advocacy, networking, technical assistance, and partnerships with international donors were the key ingredients of change. Favorable policies are present, yet the implementation is facing problems due to post-evolution problems, lack of integration across continuum of care, and insufficient financial allocation, which is very important. That I think money makes the mayor go. So we need more and more money to achieve our results, and efficient utilization. Resources are there, but we need to efficiently utilize them. And almost all interventions mentioned in the latest documents have been initiated. So now it's important to scale up and support advocacy, convert devolution into opportunity, bring in more evidence, and strengthen services by developing cross-sectoral linkages, support technical working groups, and facilitating curriculum revisions. I think it's very important that our upcoming new generations are taught the new messages which we want to get, and support best practices scale up. So I would like to thank you with an appeal that let's do all we can so no newborn dies due to a preventable cause. And I'd leave you with this food for thought that sometimes it doesn't matter how many resources you have. If you don't have how to use them, they will never be enough. So I really feel this is the case we have in Pakistan. Thank you so much. Thank you.
Thank you very much, Dr. Samia. And since I've started working and known Dr. Samia, she's been very passionate about maternal and newborn health, and especially about quality of care. With this, our speakers and our keynote speaker have presented the case and have covered the objectives for the workshop, for the session. And I hand over to Professor Dr. Ghazna Khalid for leading the discussions for today. Thank you very much.
Assalamualaikum. Thank you very much. And I thank everybody for the opportunity to be able to talk about something that's very close to my heart. 20 years as an obstetrician, and we are still facing the challenges for maternal and newborn mortality, where we know that 80% of these deaths are preventable. I congratulate the speakers. I'll do it and take the salient features of each speaker so we can get take-home messages. Dr. Asha, thank you very much for such a succinct and heart-provoking message. I think one of my mentors was Mohammed Fathala, who was the president of FIGO and the Federation International Gynae and Obs. And he once said, which is a very famous quote, and I'm sure many of you have heard it, that mothers and newborns don't die because we don't have the facilities available or the know-how available to prevent them. They die because the governments lack the ability to save them. And I think that takes home some of the things that Dr. Asha had said in his keynote speech, in the sense that it's not business as usual. We need to look at what we can do as a country to promote advocacy and policy direction at governmental, both in the upper houses and lower houses of parliament, to see how we can gather support to bring towards auditable standards. Why isn't maternal death a notifiable event? I think that Dr. Samia mentioned MPDSR in her recommendations, and we are still struggling with the fact that we do not have maternal death as a notifiable event. Neonatal death should be notified. If we, in a country where you need to notify and present your NIC card for a SIM card, does that mean that our mothers and babies are less valuable than mobile phones? It's just food for thought, and it's what we need to do as a country to try and put this on the agenda, because until we know how many people are dying, what are the auditable standards, and we work on the MPDCR category, we are not able to understand the full mountain of this very doable and achievable task of stopping mothers and babies dying. So with that, I will touch upon what Dr. Nabila has said. And Dr. Nabila and I have been working in the background to look at strategic purchasing. And so one of the reasons one of the areas that we need to strengthen in Pakistan is the neonatal units, so the care of small and sick newborns. We know that we don't have enough neonatal units. We can only achieve hospital care in working with private organizations. So if we look at the model of public-private partnerships, we're more likely to achieve some of this accelerated progress. Bring in our private sector. We know that 80% or 70 to 80% of healthcare is provided out of pocket. It's private. So why not engage the private sector and make sure that we get some of the impetus or some of the, the strength behind our neonatal care, level 3, level 2 nurseries that we so lack. We also talked about, Nabila mentioned that we've not really achieved targets within PPH and preeclampsia. I mean, I have to say, as an obstetrician, my hand up, it's shameful. In something that we know, magnesium sulfate stabilizes women. I have visited many units that don't have magnesium sulfate. And we need to really drive that home without a blame culture. PPH, I mean, I think our maternal mortality range, PPH is from 40 to 52%, depending on which province you're looking at, and even more. So when you know what saves women, and we can provide the skills to be able to do it without really much other than cesarean section facilities and blood transfusion, then we really need to think about what Dr. Samia said about why are these people dying, and look at the concept of service redesign. We don't need to transplant. There is Margaret Crook's group at Harvard who's looking at service redesign. We don't need to transplant some other countries' notion to our country, but what we do need to do is look at how we can avoid the delays in transfer and referral to bringing everything closer. And institutional delivery, you very rightly said, has increased, but do we need to have BMOC and CMOC? Can we not have integrated care or very nearby care so the delays attributable to referrals are reduced? Because we'll never have the correct referral system. It's very difficult. So why can't we bring it closer together? Maternity waiting homes, different ideas of how to integrate care. So I think I congratulate my three speakers. I said what I had to say, which is close to my heart, that we're not doing enough as a country to register maternal mortality and neonatal mortality as a notifiable event. And I think until we do that, and we give them the same status as mobile phones and SIMs, then we are not going to move forward on that. We need to push our leadership, whatever leadership, at every different level, to advocate. The Global Financing Facility, for those who don't know, is a multi-stakeholder organization housed at the World Bank, and Pakistan was signatory to the GFF Fora in 2019. It was started off in 2015, and the sole mandate is to provide health and a voice to mothers, newborns, and adolescents. I'll stop there. Thank you very much.
So before I request for comments from the chair and co-chair, we'll take some comments from the participants. I know that your was existent, that was the newborn session only. So the floor is open for comments. And the speakers present. The mics, I think they work.
Thanks to my all colleagues We worked together for the last 2 decades, I think, together in the maternal health. And we invested a lot, more than 200 billion on reproductive health in Pakistan. I'm a field person. I worked in field starting my career as a lady health worker program officer, reaching to the national manager or deputy national manager of an NCH program. So we are the pioneer of LHWs, CMWs, and all these interventions. I think where we lacking behind is the facility provision. In Quetta, once I was told by Joe Vizay Saab, Sardar Joe Vizay, that Doc Saab, don't educate us. We know, but provide us single LHP or LHW or anything. We provided them a CMW who delivered, I think, more than 370 deliveries in a year. So what I'm facing right now, I'm in a PIMS. A mother came to the emergency. My gynecologist refused that you are not registered. So we are fighting for them because no, I'm an administration. Then how you can refuse? So in this dilemma, usually mother delivered either in a corridor or they passed away or it is delivered, then there is no facility for the neonatal care. We have only 120-bed ICU. So services are more required to be utilized on educating gynecologists rather than the community. Thank you.
Assalamu alaikum ji. My name is Rafia. I am from Forum for Safe Motherhood, which also serves as the Pakistan chapter of White Ribbon Alliance. I would like to start by building on the presentation given by Dr. Samia. It was a good presentation. Nothing is scarier than facts and figures, but they really open your eyes. I also like the fact that you highlighted some positive changes which are taking place. It's always very heartening to know that. At the same time, I'll agree with Dr. Ghazna that the country is not doing enough and a lot more still needs to be done. Now, building on that, I would like to take this opportunity to inform the House of another good news, in the making. Recently, a technical advisory and accountability group, which is focused on EPMM and ENAP, has been set up. It is being chaired by Health Services Academy and co-chaired by WHO. And our organization is providing the coordination and other logistical functions for the group. Now, this group has basically been established for the purpose that I could see is being highlighted here, to bring together the entire MNH community together, to bear on decision makers, to, I like the term used in the presentation, have a political and social agenda. Make sure that EPMM and ENAP is out there and everybody is aligned and we're all working towards meeting its targets. That's what the STAG is working on. Some work on it has been done. We have notified the group and its meeting has also been held. Another meeting is planned for this 9th. To inform the working of this group, a detailed landscaping analysis has also been carried out, and I can really see that feeding into the country level report that you're aiming for next year. We are having another meeting of this group on next Wednesday, which is November 9th. All of you are invited. Please do come. It's a hybrid meeting, so you can even join online. I think it's important that this session has given us an opportunity to come together and see what others are doing on this front and to align our efforts on this. This tag is here, a platform is there. Let's use it for taking this agenda forward. In the next meeting, when we are sharing the findings, we will also be working towards developing an advocacy roadmap for the future. And we would really like input from everyone over there so that we can take this thing forward. So, and at the same time, UNICEF, obviously, others as well, we would like, you to align our efforts with us. And we can always go over, even at one time, the TORs of the group and see how we can augment it, make it more effective. We can even enhance its composition at one time. So a platform is there, let's use that. So I'm sure by aligning our efforts, we'll be able to make more substantial effort towards the objectives. Thank you so much.
Gigi, please, Dr. Samia, please.
Thank you. Sorry, I missed your name. Rafia. Thank you, Rafia. Yesterday, actually, I got a WhatsApp invitation to a group, the one you mentioned, and I was a little surprised to see that, we have been working very hard on ENAP for the last almost since 2014. And it came as a surprise for me that we were not aware, that this group has been created. So, but I'm glad that at last we were taken on board. So we are under the, like we understand it, that we have a technical working group in the country, RMNCH Technical Working Group, and a National Steering Committee for Newborn Survival has also been formulated. So I think we do not need many forums to discuss newborn survival issues. There should be one forum where people are there on the same wavelength of understanding. They can take up the recommendations and also take stock taking, that what was agreed has been done or not. And those people who are part of that group are made accountable. Because what I have seen, and I have seen in the past as well, that several groups are formed, meetings are held, people come, they meet, but nothing happens after that. There are reports which are nobody even reads them. So this is my request to you to please, this would be very good to have the first meeting, but just to let you know that I have Dr. Khwaja Masood sitting right next to me, and he actually initiated the National Steering Group for Newborn Health. And the invite for the first meeting was sent to the members for 31st October meeting. They were notified, TORs were shared, they were called for the meeting, but because of the political situation in the country, we were receiving calls from different people that they are a little hesitant to travel. So we decided that there's no urgency, so let's postpone it. Because if people are not comfortable, there's no point in having that meeting. See, so we delayed it, but this forum has been created, and HSA is also part of that. So I think there's no point in having parallel, forums to discuss the same thing. Thank you so much.
Thank you, Dr. Samia.
I think because this meeting has brought us together, so डॉक्टर खालदा आप इधर आए डॉक्टर साहब रजाला हमें हमेशा गलत हो गया इधर आइए प्लीज ना दिस इज योर प्लेस आई थिंक जैसे डॉक्टर समिया ने बताया कि एक टेक्निकल वर्किंग ग्रुप है जो न्यूबॉर्न सर्वाइवल एजेंडा को लेके जा रहा है और हम जो अशेबर ने भी कहा और हम सारे फील करते हैं कि जिन कंट्रीज में प्रोग्रेस हुई है वहाँ सिर्फ गवर्नमेंट के प्लेटफॉर्म से प्रोग्रेस नहीं हुई, वहाँ एसोसिएशंस ने भी बहुत काम किया और वहाँ सिविल सोसाइटी ने भी बहुत काम किया। हमारे जो एनजीओस पे अनफॉर्चुनेटली क्रैकडाउन हुआ, उससे कितना वैक्यूम क्रिएट हो गया कि एमएनसीएच में जितनी पहले एनजीओस काम करती थी अब उतना नहीं रहा, उनकी फंडिंग भी कम है, उनका फुटप्रिंट भी कम हो गया और जो आवाज़ें हैं या वॉइस है वो उससे भी कम हो गया। सो आई थिंक जो, और थैंक यू रफिया कि आपने कहा कि टीओआरस को हम रीअलाइन कर सकते हैं, देख सकते हैं। आई थिंक वी वुड शेयर जो डॉक्टर समिया ने बताया और एंड ऑल्सो लाइक हैव लाइक दैट मैकेनिज्म के मे बी हम CSOs के एक फोरम हमें बहुत ज़्यादा चाहिए जो उस सेंस में हो जाए, जहाँ प्रोग्रामिंग का है वहाँ पे आप, और फिर हम इकट्ठे कैसे हो जाए, है ना जी।
Nazna has also said that apart from the fact that governments, I'm from population development, government of working for. So apart from the fact that the government is doing the providing services, we know that there are a lot of people who go to the private practitioner. So a suggestion is that we should, the government, even if they are not, even the government, even if it is not providing any money or anything to the private practitioner, at least they should involve them in the planning. Imagine the whole burden of Shifa International coming to PIMS. So they are there, and in the rural setups also they are there. So it's, if we just make them sit with you on the table, and then modalities do develop, people come, and so once you're addressing the one forum, you'll be actually addressing a lot more.
Thank you. First of all, definitely working for newborn survival strategy have opened a lot of new venues for me, especially after working for more than almost 15 years for maternal and child nutrition. And definitely both areas are interlinked. Survival also depends upon the health and nutrition of mother, and vice versa. And the birth of a healthy child then also leads to survival of the children under 5. That was my interest. That I was trying to come to this group, and because we are working together, the ministry is working together with UNICEF and other development partners for development of this newborn survival strategy and costed action plan for the country, as well as revision of the provincial newborn survival strategies. So this was a common goal and agenda. And now talking about the multiplication, I mean, working in the ministry, with the ministry for the last many years, I have seen that every new intervention on every new support brings about a new technical working group, a new steering committee, a new advisory group, and all these things. I have notified myself so many in the past. For the last couple of years, of course, we have then decided to merge these different. I mean, if we have an IYCF group, then we go for the adolescent nutrition, then we go for the maternal nutrition. So it is better to have one MAIYCN, and the RMN, ACH, and NTWG is sort of that merging to bring everything together. Similarly, when we started the process of development this newborn survival strategy, and we thought that we should have a separate group for strategy only. We discussed with different stakeholders, and Dr. Bhutta and other colleagues who are working, the different pediatricians, gynecologists throughout the country, including the PPA, Neonatology Association, and Gynae Ops Association, they were of the view that it should be a broader one, covering the total agenda of the ENAP and EPMM. Then we discussed it, how we should place it. We have a National Health Task Force at the federal level, which was notified a few years back, and it has been de-notified again. So the idea came from the government that, okay, we should have a National Health Task Force, and different other steering committees should be below that umbrella, and instead of going to different organizations or partners, they should be reporting to that. I mean, they should be accountable, as Dr. Samia mentioned. But of course, I also endorse Dr. Nabila's point of view that government cannot do everything and all the things. So we definitely need the support of different partners, donors, civil society, etc. So thank you very much for your support and developing this forum. But I think at the end, maybe after some time or reviewing the TORs, we should end up with only one forum. At present, I will not say that why this was done. I mean, it was definitely done with a good intention, and it would definitely yield positive results in augmenting the and taking forward the overall agenda. But as I mentioned, merging different small technical working groups, small steering committees, etc., to a bigger one is the ultimate goal, so that all the stakeholders come together at one point and there is complete harmony and understanding of different sections of the health service delivery components. So that's what, as Dr. Nabila mentioned, we will share the TORs with each other, find out the commonalities, and how at the end of the day we can bring both the groups together and overall under the umbrella of the Ministry of Health.
Thank you, Dr. Masood. We also have Dr. Ashper online. So, Dr. Ashper, if you can hear us, if you have any comments, please feel free to share. Thank you.
Thank you very much. I think I'm very much heartened by the comments provided. I just want to reiterate that as far as maternal mortality reduction, newborn mortality reduction, and stillbirth reduction is concerned, in all the 8 South Asian countries, including Pakistan, we are on the right track. All the trends are very clear. And in due process, if you follow the trends and considering everything will continue, the countries will achieve. That's not the question. But I think the question we are facing is we need to achieve these targets within the coming 7 years, which is the agenda of this session. How do we do it? How do we accelerate? For that, as Dr. Masood has also clearly said, we have a solid program. And that is the responsibility of governments, I think. Policy and program. We have no issue there. Those are very strong in all the 8 countries, including Afghanistan. These are solid. We couldn't find loophole. And as I said, I had that opportunity for about a week or so to discuss, but also to visit facilities in Pakistan. And in terms of program, there were no loopholes which I could say, no, here something needs to be done, or this needs to be introduced. There was nothing. How do we accelerate? Rapid acceleration or achieving huge targets at the national level requires a social agenda, not a program. Program will go at its own pace. Program is, funds, it is interventions, it is plans, it is strategies, it is monitoring. It will take its own time, it will achieve. If we have to accelerate it to a level that the SDG is requesting us, then we need to look at how do we transform the program into a social policy agenda. That means, in addition to ministry, in addition to UNICEF, in addition to providers and so on, who are already and partners who are already working that, media need to understand that. All policymakers need to understand that. The common man on the streets need to understand that. All the 6 million mothers who are delivering every year need to understand that vision. Just let me give you one example. When we were visiting the district, there was a discussion that the district had this many number of ambulances. And if we add 3 or 4 ambulances, something can improve. So I immediately responded, no. Because even if we add those 4 ambulances, it will not transform anything. What we need is, because in other countries we have this experience, the countries where they have transformed this program into social agenda, we have this experience. That if you transform it to a social agenda and all the community accepts no death or skilled birth attendance as a social agenda, every vehicle in that community will be an ambulance. We have worked in African countries where youth became ambulances. Each time a mother went into labor, youth organized themselves and transported mother to a road Because in Africa, Africa is not like South Asia. Road is far away from the village where the mother is. So youth organize themselves as through, like to carry the mother actually to where the road is. And then everyone who has a vehicle supports, because this becomes a social commitment. This is what we need if we are going to achieve maternal mortality reduction. And communities will go that. Motherhood, newborns are precious. Communities will work to that. That's what Professor Mahmoud Fatala said. As Professor has said, when Professor Mahmoud Fatala said what he said, that's what he meant. If societies believe that it is worth saving the life of mothers and newborns, and if we do the advocacy, they will. There is no society in the world that will not believe that. They will transform themselves to achieve what needs to be achieved. Maternal mortality reduction has been achieved to very low levels by countries that are much, much, much more poorer than Pakistan. I can mention those countries. It's not important. It has nothing to do with wealth. But those countries achieve them because society, they energize the society, and that society, said, no, a mother should not die. A pregnant mother and newborn should not die. So how do we transform this program, excellent program that we have, into a social agenda, into a national social agenda, which says no mother should die in Pakistan. It's no more acceptable. No newborn should die in Pakistan, no more acceptable. This requires skills beyond program. This is about communication. This is a different needs, and a communication strategy needs to. It should be branded, even the name, what it should be called and so on. That is a communication expert will develop that. But we have to agree on this. Unless we do that, then we go by our program. Program will take time. Program has its own pace, it's its own thing. There is a water program, there is an infrastructure program, there is an education program. All of them require budget, they plan, they go by bureaucracy. And that cannot be adjusted to SDG. So this is what I am trying to say. But those policy considerations, if Health Service Academy can look at them, because the policies, come through. That is one of the great achievements of this forum. I would be happy if those things can be considered. For example, midwifery. We have midwifery in Pakistan, but we don't have a midwifery model of care. When a country is asked, who takes care of pregnant mothers and newborn in this country? If that country is not able to answer midwife, that is the correct answer. That is the only correct answer. If that country answers obstetrician, that's the wrong answer. If that country answers nurses, that's the wrong answer. If that country answers doctor, that's the wrong answer. Midwife is the correct answer. That's what's called the midwifery model of care. And countries who have good maternal newborn care that is one of the key things, the midwifery model of care. We need to achieve that. We already have it, but we need to make it a national program. And I have mentioned some things, private sector and those family planning, family spacing. These are some things which we can do and we should do, and we must do to accelerate. Thank you.
Thank you, Dr. Ashper. Thank you very much. I'm really thankful to the participants for the very healthy discussion which has been generated. I will now invite the co-chair, Dr. Malik Mohammed Safi, for his remarks on this today's session, which is accelerating progress on maternal and newborn survival and fast.
Thank you, Dr. Mariam. I would like to thank organizers for organizing this very important session with the permission of chair. A lot has been said, and we have heard our honorable speakers pointing out to the key areas of concern, tracking progress, and their suggestions in this regard. One thing is very clear, that without private sector public sector alone cannot achieve what we intend to achieve. And another important area is that engaging academia along would be of utmost importance across the country through undergrads, postgrads, students of medical sciences and other areas. So this is a lesson learned over 70 years of our work in this health sector. Keeping these issues in mind, way back in 2018, government, along with all the provincial governments, had agreed on the policy framework in context of universal health coverage, agreeing to the health reform agenda, which is the key outcome of SDG 3. So that was agreed in 2018, and since then, with provincial governments engaging all private entities, federal ministry has been able to come up with defining the essential package of health services at the national level and then provincial level, and also AGK GB. So these were based on the Disease Control Priority 3 program, which are the global best practices, which our distinguished speakers also mentioned, very articulated very clearly. So that process has completed, and now the implementation phase is going to start since from the first quarter of 2023. The implementation modality of this essential package of health services, in which all partners, UNICEF, WHO, USAID, Global Financing Facility, FCDO, they all supported government's efforts in defining these, and then these were endorsed by the steering committees of provincial governments as well as the Interministerial Health and Population Council at the national level. So that dialogue is completed, and now implementation modalities through the National Health Support Project would be starting. The government had engaged World Bank and health development partners for almost $432 million to start with for implementation these essential package of health services. The special focus would start off from the community, lady health workers and all our community health workers, and the primary health care set up to the public sector with engagement of general practitioners to engage the private sector along. So this would be the way forward in this context in order to what we were talking about, reducing preventable deaths to start with, and to the essential interventions to be included within the package pertaining to newborns, maternal health, and other NCDs and communicable diseases as well. So we would like to apprise this forum as well as our other wider forum as well, because this would be needing a continuous awareness of all of our public health experts within public sector, outside public health sector, academia, to create awareness about what UHC entails. It's not social health insurance, or social health insurance is part of UHC as an agenda. Yes, that is correct, but it is not health insurance what misconception or concept is about within the country. So that we are trying to improve and communicate to our policymakers. So a lot of important steps have been taken, and Dr. Razna pointed out towards engaging political Senate, the National Assembly, and also the provincial assemblies to secure funding for the health sector for the future as well, because we have been witnessing very low funding towards health sector of the country, which has resulted in what we are having in front of us. So the bottom line would be that all partners The private sector, they have to keep themselves engaged and align their support with the essential package of health services that would try to ensure quality of care and would ensure provision of health workforce, all supplies, all commodities, at where this process would start. So it was envisioned that this process would, this implementation would start from 40 districts across the country. Still, Balochistan is not on board. Surprisingly, 3 provinces are on board in this project, and however, their funding has been kept with the finance and World Bank. So as soon as the Balochistan government agrees to this NHSP program, so they would be engaged. In fact, Balochistan government is the main, when we were talking about equity, so addressing equity, so Balochistan cannot be left out. So that we are trying to bring across the policymakers of Balochistan government that they should come up and join this very important health reform agenda, to which health sector and their planning department has agreed, and the essential package of health services defined. So thank you once again for this important session, and through this fora, I wanted to just share this very important aspect that whatever we have been facing and we are facing, so collectively we can we would be able to address that with collective work and by joining hands with private sector. One more thing which I wanted to just point out was about the governance mechanism which has been developed for this UHC agenda. The Interministerial Health and Population Council, that's the highest forum at the national level. Under that, there's a UHC country platform in which is chaired by Federal Minister. All the provincial secretaries are part of it. All development partners, UN agencies, CBOs, private sector, they would be part of this engagement. And under that, there's a National Advisory Committee headed by Director General Health, and provincial DGs are part of it, along with our important UN partners, where technical matters are discussed and finalized and then taken up to the UHC platform and to the higher forums. At the bottom line is the technical working groups, to which we were just mentioning. There are other working groups as well, apart from RMNCH, communicable diseases, health systems, and NCDs as well. So in totality, the health sector is being looked at, and we are encouraging provincial governments to adopt similar sort of governance mechanism for the health sector, so that this whole process is taken to in a streamlined and in a very coordinated effort. So thank you very much.
Thank you very much, Dr. Safi. And now I have the pleasure of requesting the chair, Dr. Saima Hamid, Vice Chancellor, Fatma Jinnah Women University, for her closing comments. Thank you.
Thank you very much, Mariam. And let me just begin by thanking all the organizers of this conference and all the stakeholders for attending today's session. I believe that this is a very important agenda, and seeing it take this amount of visibility in this conference, I must compliment you, Mariam, in your endeavors. I have seen your career right from the start at Health Services Academy, and it really gives me immense pleasure to see you where you are today. Now, having said that, I would like to take stock of this very important scientific session that has been organized today. All the speakers really put the case forth very well. The task, in fact, was started once Pakistan ratified to the SDGs, and that's where I see there's a lot of lots of initiatives have been underway. I must say they have matured to different levels by now. But one important thing, so I would not like to repeat what the other colleagues have just said. I am in agreement, but I believe that what Dr. Ashwas just said about putting it on the social agenda is the way forward. And I'll tell you why that is. We are all from a health background. And when we look at the determinants that are affecting both women and child health or newborn child health, they're all embedded in the socio-economic determinants, right? So are we really addressing that comprehensively? That is not the prime role of the Ministry of Health, no doubt. But then again, there are so many other key players that are out there. Lots of projects that have or initiatives in health that have been undertaken. If you look at the reports of the last couple of decades, you would say that on policy grounds, we've been doing well, but we've been poor implementers. So it's time to advocate the implementation science, embed these implementation competencies across different initiatives. So while we are working on the program, because the planning that Dr. Safi, you rightly pointed out, the ministry is steering lots of initiatives. It's important that while these strategies are very much in place, the program's implementation of the targets, materializing that at national level would take time. So what is that out-of-box thinking that is required at this stage to gel these different fragments together and maximize our yield? What are the effective ways of functioning together? Lots of things that have been reported by all our colleagues, especially Dr. Nabila and Dr. Samia, were in nascent stages just a few years back. And that was the time when Mariam, you and I and Dr. Savi were working on the localization of the SDGs 3. So there is clearly a way forward. There are custodians of certain indicators which have translated those, in order to achieve those targets, a lot of people have come together. But what it basically identifies the need for is to work together across different sectors, and that implies private sector, the NGOs, and it's all about collaborative learning. And in that respect, I really loved your, two words at the conclusion: refocusing and realignment. That's the gist of it. So how do we realign ourselves, refocus? In the absence of real-time data, that becomes a real challenge. But at the same time, there's enough data to bank upon and revisit where we stand and what is the way forward. So if we were to look at the low-hanging fruits around us, I would say clearly academia is one. Has the word even gone out to a lot of universities? There are about over 300 universities across Pakistan. So why not, collaborate with them, get the word out, be more visible, and it doesn't require a lot of resources. I tell you, that's not on, but it's the larger ecosystem that we have to take into account. It's that macro level interventions that are required. And I believe that together we can do that, because if we just look at the gender disparity index, because that's what adds to the, or shows that that's where these 4 domains of health and survival, educational attainment, women empowerment, and then political representation. So where are we on all those 4 domains? And the horrific facts today are that in 2022, we rank at 145th position of 146. So that's, and just looking at those 4 domains, health and survival is one area we've actually done well. So can you imagine? It's time to have an interdisciplinary approach, and that's our way forward. So I often tell my colleagues that SDG 17 was put at the end for a reason, because it's the most difficult to work across different levels, whether we are going horizontally, vertically, and it's all about a lot of fragmentation that exists out there. Who can bridge those gaps and bring people together on one platform? And in that respect, I strongly urge you all to revisit your proposal about, having lesser number of groups. Because you see, at the higher tier, you need to have the representation, but then the smaller clusters need to get together because there would be one geographical area where an NGO would be taking lead. There's another one where the government would be taking lead. It's all about how we are going to think out of box and within our existing resources, make it happen in the next coming 7 years. So inshallah, we work together and with this spirit, we will make a dent. So I wish everyone the best.
Thank you very much, Dr. Saima. So with this, I thank all the speakers, all the participants for your active engagement with this session. And we do have souvenirs for the speakers, which I will request the chair and co-chair to please come up to the front and present them to our speakers and the discussant. And while you do that, while this chair and the co-chair are making their way here, the session, you are the stars of the session, but the session would not have been possible without the excellent support and help of Dr. Anam Wahid, Mariam Avan, Javeria, and Hassan. So please stand up and take a bow and, please clap for them. They supported me really well. Anam is actually the one who's been bugging you the most. So please. So may I please request Dr. Ghazna Khalid? Thank you, Dr. Ghazna, for your time today. Dr. Nabila Zaka. Thank you very much. Dr. Nabila, I'll request you to please stay here so that at the end we also take a group photo. Dr. Samia Razwan. Thank you for an excellent session. My reporters had been busy writing the whole time, so I'm sure we'll get a good policy brief out for this session. So Dr. Ghazna, Dr. Samia, Dr. Nabila, and my excellent team, please join us for a group photo, please. Thank you. Dr. Ghazala, Dr. Hajra, please join us. And Dr. Masood, please.
यूनिवर्सिटी के जी कॉन्सेप्ट के काफी बच्चे आए हैं मैं इंशाल्लाह उनके साथ राब्ते में हूँ और मैं ना सबका जनरेट करवाऊंगी आप मैम अगर अपना नाम और ईमेल आईडी मुझे बता दीजिए डॉक्टर निखिल सुल्ताना Professor, Department of Health Informatics, Assistant Professor, Department of Health Informatics, Health Informatics, COMSEC University Islamabad, COMSEC, ठीक है, Dr. Nikhil, मैं okay, Dr. जी, Dr. Nikhil, at COMSEC, at COMSEC, मैम स्पेलिंग बताएंगे? COMSEC, ठीक है मैम मैं जी बिल्कुल जी मैम मैं बल्कि आप ही के थ्रू ना आपके सारे स्टूडेंट्स की जो लिस्ट है वो मैं मंगवा दूंगी क्योंकि अगर कोई मिस भी हो गया तो भी वो अरेंज हो जाएगा तो आप ई सर्टिफिकेट भेजिए जी भेजिए जरूर भेजिए थैंक यू सो मच नो प्रॉब्लम आपका नाम मरियम अवान डॉक्टर मरियम अवान मैं आपको देखती थी आप बहुत मेहनत से काम कर रहे हैं थैंक यू सो मच ये फालतू है ये यूज करो